The Genuine Article. Discussion and commentary based on articles from Jack.
Hello, I'm Tony DeMaria, the editor of Jack, here with another issue of Inside Jack, and I'm talking to Dr. Edward Hulton, who's on the staff of Walter Reed Hospital and who's completed a very nice study about to be published in Jack that deals with the prognostic significance of coronary computed tomography angiography, or CTA. And although there's a lot of information about the diagnostic value, there's been less information about prognostic value, primarily because the studies have been relatively small. And so what Dr. Hulton and colleagues did was a meta-analysis. They managed to identify 19 studies, including over 9,500 patients. And as they looked at these studies, they analyzed them for the evidence of major adverse cardiac events or death. And in fact, what they found was that if a patient had any obstructive coronary disease at all, more than 50% in even one vessel, that the annualized rate was just under 9% for events or death. And if they had a negative test, it was under 2%. The rates for death as an absolute were twice as great if you had some coronary obstruction on the CTA. So evidence of rather significant prognostic power. So let me ask you, Dr. Hulton, you dealt primarily with patients who were symptomatic. How would this apply to patients who were asymptomatic?
Thank you for having me. That's an excellent question. These studies were all in patients being evaluated for symptomatic angina. And there are a couple of studies of asymptomatic patients, but the evidence is still growing. And so at this time, it's being used in research studies of asymptomatic populations, but there is no widespread recommendation or appropriate use statement that says that CTA should be used in asymptomatic populations. The problem is that you find a large burden of subclinical atherosclerosis, but very few of the asymptomatic patients have, in fact, obstructive disease, and so the population is probably overscreened.
So now one of the issues that always comes up is that revascularization is an endpoint, and so just the finding of an obstructive lesion may lead to the so-called oculostenotic reflex. What did your data show if you eliminated revascularization as an endpoint?
That's an excellent point. There is a self-fulfilling prophecy after a diagnostic test that patients who are found to be abnormal will be revascularized. However, heart events in terms of death and MI still occurred at significantly increased rates in the patients with obstructive disease, 2% per year for death and MI. And so even in the absolute events of heart outcomes, there was a significant difference.
So how does the prognostic significance of CTA compare with, say, stress echo or stress radionuclide techniques?
That's another excellent question, and that was one of the primary motivations that we carried out this study. There are a handful of studies that provide comparative clinical outcomes, but there was insufficient data in this meta-analysis to compare amongst modalities. However, what is reported are the summary statistics for stress echo and nuclear stress testing, and in fact cardiac CT in terms of prognostic value is comparable to those tests. But I think it's an area, I think it's an area that warrants further study.
So last question, the data are pretty strong. If you have a negative test, your prognosis is excellent. What do you do with the patient who has a positive test?
I think that's a gray area in terms of patients that have mild disease or worse stenosis less than 50%. Certainly most practitioners are aggressively medically managing them, but there's a lack of outcomes data for the management of subclinical atherosclerosis that's detected on imaging studies at this time.
So our information about coronary CTA continues to increase. We need data like this to properly place this powerful tool in our diagnostic armamentarium. And I'm talking today with Dr. Jerzy Chen, and Dr. Chen's assistant professor of medicine and cardiology at Yale. He's the first author on an intriguing article about to be published in JACC that deals with the amount of radiation exposure that individuals are undergoing in the United States due to cardiac imaging procedures. So tell us a little bit about your study, Dr. Chen.
Well, this is one of the first studies to look at cardiac radiation exposure from cardiac procedures on a population basis. So we took a large data set of privately insured patients, over 900,000 patients, tracked all their cardiac imaging procedures that used ionizing radiation, tabulated it up over 3 years, and then see how many patients received a large amount of radiation.
And what did you find?
We found that approximately 10% of the population received a cardiac imaging procedure that involved radiation. On average, the patients who did have a cardiac procedure received 15.6 millisieverts of radiation over a 3-year time period. And that's about 5 times the annual rate of radiation received just from background sources in the United States.
So you found a fair degree of exposure to radiation. I assume most of it was from radionuclide procedures.
That's right. About 3/4 of the radiation exposure was due to myocardial perfusion imaging, such as SPECT or PET imaging. And almost another quarter were due to cardiac catheterization and stent implantation procedures. And the remainder were due to smaller radiation doses from electrophysiology procedures and very small amount from cardiac CT.
So when were these data gathered? Was a lot of cardiac CT being done at that time?
This was done during 2005 to 2007, so there wasn't that, the amount of cardiac CT was actually not high at all. So in contemporary clinical practice, most likely to be higher.
Yeah, I was struck by the fact that there were a small number of individuals who had received really very, very large doses of radiation.
There were a few thousand people who received much more than 50 millisieverts. In fact, the highest amount was almost 550 millisieverts. Of this group, there was several thousand people who had more than 5 cardiac catheterization procedures and more than 3 myocardial perfusion imaging procedures during this 3-year period, accumulating to a very large radiation exposure.
Of course, that brings us to the most important question of what it all means. As I recollect, virtually all of our understanding of the cancer risk of radiation exposure comes from the atomic blast in Japan. And in fact, there's very little data where specific cancers can be attributed to radiation exposure in individual patients. So what's your interpretation of the meaning of the radiation exposure you found?
Well, the meaning, the radiation exposure meaning, that certainly some of the radiation exposure is most certainly appropriate and justified if a patient needs multiple stents or if they need multiple procedures. I think what this study shows is that there are some instances where perhaps radiation can be reduced. For example, in young patients, aged 19 to 35, there were a number of these patients who received on average 15 millisieverts, and this population will probably have the highest cancer risk because of their young age. Whether these individuals, and most who actually mainly had most of their radiation exposure from myocardial perfusion imaging, could have a substitute procedure such as stress echocardiography, or even an ordinary exercise treadmill remains to be investigated to actually reduce their long-term risk.
So I think you make a good point. Certainly that if diagnostic radiation exposure is required for the clinical condition, that we ought to go ahead and do that. Whenever possible, we ought to limit radiation as much as possible. Very interesting data that you've reported for us. Thanks very much for being with us.